8:40. Is the
Yeah, I think we can start now.
Okay, sir. Good evening, sir. I am presenting the case of Mr. A, who is a 58 years old male, resident of Kathmandu, Nepal, who is a shopkeeper by occupation, and he was admitted on 10th of January and was examined on 11th of Jan. History was given by himself and his wife and seems to be reliable. He presented with the chief complaints of shortness of breath for past 5 months, feeling of pounding in the chest for past 15 days, fever for last 10 days, cough with pink for the sputum for past 5 days. The patient was apparently well 5 months ago when he developed an insidious onset, gradually progressing shortness of breath. Initially, he could manage his daily activities comfortably, but over time, he started feeling breathlessness while walking short distances and now even at rest. Over the past 15 days, he started waking up suddenly in the middle of the night, feeling suffocated and gasping for air. He needed to sit up to relieve the sensation, and it took 10 to 15 minutes to subside. For the past 10 days, he had difficulty in breathing while lying down flat, needing to prop up himself with 2 to 3 pillows to sleep. He also complained of feeling of pounding in the chest for past 15 days, which was 2 or 3 times in the week, triggered by physical activities. And these episodes were associated with shortness of breath and fatigue. He also complained of fever that began 10 days ago, that was continuous in nature, relieved with medication, and was associated with chills and rigor. He also reported that he is having cough, which is associated with a pink frothy sputum for the past 5 days. There was no history of any joint pain, rash, burning maturation, loose stools, abdominal pain, or yellowish discoloration of skin or eyes. There was no history of weakness of the limb or difficulty speaking. There was no history of lower limb swelling or abdominal distension. There was also no history of bluish discoloration of the face or oral cavity, no dysphagia or hoarseness of voice, no history of chest pain, fainting, wheezing, leg swelling, or significant weight loss. Past history. At 12 years of age, the patient had recurrent episodes of fever with joint pain and sore throat. He was advised to get some injectable medications, but he didn't comply with the treatment. There was no history of diabetes mellitus, hypertension, or tuberculosis. He is a non-smoker and occasionally consumes alcohol. He is taking mixed diet, and his sleep is disturbed for past few days due to breathlessness and palpitation. There was no significant past history. On the basis of summary, on the basis of history, the summary could be a 58 years old male shopkeeper from Kathmandu, Nepal, presented with progressive shortness of breath over 5 months of grade 4 NYHA, recent onset orthopnea and PND, with high grade fever for 10 days and productive cough with pink frothy sputum for the past 5 days. Past history is significant for untreated fever with joint pain in adolescence. On the basis of the summary, the possible differential diagnosis could be a valvular heart disease that is of rheumatic origin, a congenital heart disease, dilated cardiomyopathy could be a DD also. It could be a infective endocarditis with any valvular dysfunction. It could be also ischemic heart disease with mitral regurgitation, and it could be a lower respiratory tract infection also.
Okay, yeah. We shall go by history right now. So
Sir,
just show your that chief complaint right now. Chief
sir,
complaint.
sir.
Okay. So your first complaint you said was breathlessness since last 6
5 months.
months. You're saying
Yes, sir.
since 5 months. 5 months. So it was breathlessness followed by palpitation. You said.
Yes, sir.
So over a period of 6 months, it has progressed from, according to you, from New York Heart Association 2 to 4. You are saying at present,
Yes, sir.
no?
Yes, sir.
Okay. Okay. So what is the differential diagnosis only for breathlessness and palpitation? What do you think it could be
Sir, it could be
based on your own breathlessness and palpitation?
sir, it could be arrhythmias like atrial fibrillation or supraventricular tachycardias. Sir, it could be heart failure, either acute decompensated heart failure, or sir, it could be a valvular disease like mitral stenosis or mitral regurgitation, sir.
Okay.
On the sir,
So based on valvular, what do you think? Which possibility looks like to be more common? Dyspnea followed by palpitations.
sir, it
Which
could be
valvular lesion do you prefer?
sir mitral. It could be mitral stenosis or mitral regurgitation.
No, one among them. What do you think more? Stenotic or regurgitated?
Sir, I think it's mitral stenosis, sir.
Stenosis. Okay. So why do you think that?
Because, sir, it could be a valvular AF that is causing his palpitation.
No, but your breathlessness started first, na? It was
Yes,
breathlessness, then palpitations came into picture. No?
yes, sir.
Okay, so you didn't say palpitation was not first, it was breathlessness. So what is the normal natural history of mitral regurgitation? How does it present now? So which symptoms comes first and which symptoms comes last? Then, usually, I'm saying there could be atypical presentations all the time, but usually how do it is present? Usually
Sir,
palpitations come first or breathlessness comes first in regurgitant lesions.
sir, usually uh, breathlessness come first, sir.
Breathlessness comes first. Are you sure?
Not sure, sir. I will reach.
This it's normally in any regurgitant lesion. Basically, dyspnea is the very last symptom. Okay, so till the time your left ventricle is very compliant, usually no matter how much regurgitation may occur, if your left ventricle is compliant, it will be able to accommodate all the blood action. So dyspnea usually occurs very last in regurgitated lesion, unless and until it's an acute MR, then it's a different story. So
Okay,
suppose
sir.
it's acute because of some vegetation maybe or anything, there is acute valvular leak or due to ischemia, then the left ventricle don't have a time to compensate. No? So that time they may present suddenly with breathlessness. Otherwise, in chronic, left ventricle is very much compliant. And
Okay, sir.
usually they say that if patient develop breathlessness in a regurgitant patient, then the prognosis is very bad. Usually within 6 months the patient will die if you don't treat the patient. In MR, I'm saying. So it's basically because your LV should fail and your ejection fraction should also drop. So it's in advanced stage only. So usually the main symptoms in any regurgitant lesion, where suppose mitral regurgitation only, mainly it will be exertional palpitations. So in which in your case, it's I think it's fitting. You said exertional only, no? Most of the time
Yes,
palpitations was the
yes,
reason.
sir.
Okay. So based on that, your history is saying dyspnea is first and then palpitation.
Yes, sir.
So that goes more in and orthopnea, PND, and all these symptoms goes more in favor of stenotic lesions.
Yes, sir.
But does mitral stenosis progresses so fast in 6 months from grade 2 to grade 4 within 6 months of period? So usually, how much time does it take from the onset of MS to progression?
Sir, 10 years.
Yes, correct. Usually it takes 10 years. So here is very short history.
Yes, sir.
But anyways, if suppose there can be stenosis from long now, there can be triggers all the time. So what are the precipitating factors in any case of valvular disease? What are the precipitating factors which can decompensate a patient? Stable valvular to unstable valvular heart disease.
Sir, any infection, respiratory tract infection,
Okay.
anemia,
So any infection. Okay. Anemia.
sir, thyrotoxicosis, pregnancy,
Okay.
and sir, MI, sir, acute MI.
Okay. Ischemia. Okay. So I said most of them. Just remember them. Just if any examiner asks you, you should be telling it very fast. Okay. 7, 8 causes you should tell it off fast.
Okay, sir.
Anemia, thyrotoxicosis, infection, any infection, okay? Ischemia or arrhythmias or infective. In your history, you said fever since when? When
Sir,
it was
for 10
fever?
days. Sir, for
Last 10
10.
days.
Yes, sir.
Okay, so from last 10 days, his orthopnea and PND developed when? From last 10 days only, it was there
15
before
days.
also.
He had, sir, orthopnea for last 15 days. Orthopnea and PND for last 10 to 15 days, sir.
But the first orthopnea PND came and then the fever developed, no?
Yes, sir. Yes, sir.
Maybe fever may not be triggering it then. It was already evolving, I think, the disease. Okay. So, what do you think if a patient of cardiac patient develops a fever? What are the cardiac causes of fever?
Sir, acute rheumatic fever. Sir,
Okay.
infective endocarditis.
Okay.
Sir, fever can also be seen in MI, sir.
Am I okay? That's very atypical. Okay, it can present, but it's very rare. Okay.
Yes, sir. Matlab,
Or it will be transient only because of inflammatory acute inflammation. It's transient fever. Okay. Any other thing? Persistent fevers maybe. One more. You have said most of them. One more DD is there. Common DD you should tell.
sir, tubercular pericarditis.
Again, that's rare only. Yeah, that is possible. TB pericarditis is a possibility. One more is that usually it's myxoma, atrial myxoma or cardiac malignancy. More commonly myxoma. Myxoma, infective endocarditis, and you said pericarditis, right? Okay, so that was your chief complaint. You said cough.
Uh, Dr. Aditya,
Sir,
just go up, no, a little bit. Yeah, male and female. So please use words like gentleman and lady. That is better way of presenting. Okay.
sir.
Uh, in chief complaints, you don't need to mention cough with pink for this sputum. just cough for 15 days. All other symptoms you have written in just words only, no? Shortness of
Sir,
breath and fever and feeling of pounding in the chest. So cough only. No description of cough in chief complaints. Okay.
sir.
Yes. In HOPI, did you mention about fever in HOPI?
Yes, sir. So fever began 10 days ago. He described it as continuous in nature. It was relieved with taking OTC medications and was associated with chills and rigors, sir.
Okay. 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 Fine. You will not get this much time to write this detailed history in your exam.
Sir,
So right now you can write this much. That's okay. More you practice, you should end up writing less words, and still you should be able to say all these things later on when you present more times. No, you will be able to do it. So in your exam, maybe you will not get enough time to write all these things in detail. Okay.
sir.
Next thing is you have written Akif. I'm not sure whether it is still required, but too much of negative history is there, and I'm not sure whether that much should be uh, uh, given.
Actually, yeah. See,
So,
what is relevant that only you should mention.
Okay, sir.
And you said
so
smoker. No? Thing I wanted to say. You said smoker. Don't use that terminology. Smoker, alcoholic.
Okay, sir.
You know what is the definition of smoker?
Sir, who is a person who smoked 100 cigarettes in his lifetime, sir. He can be matlab,
Okay.
regarded as a smoker.
Okay. Correct. But usually don't use that
Yes,
terminology.
okay,
You
sir.
should say he's okay,
consumes
habituated to
tobacco.
smoking
Hmm.
uh, and addicted to alcohol. Don't use
Most probably,
alcoholic
your
smoke.
examiners will also be having at least hundreds cigarettes in lifetime.
Sir,
So they all will be counted as smoker, and then they might not like it. So
They will
don't
offend that
use
one.
such terminology.
okay, sir.
Negative history also. So if you write so many things, no,
Sir,
then people will start asking, why have you asked for weakness in the limbs or bluish discoloration? So no, only relevant negative history. No, this much in detail is actually not required. So just try to cut short. The more you practice, you will understand. But try to cut short your negative history to only important negative findings.
sir,
Okay.
sir.
And also, have you practiced presenting a case without seeing? Now you're reading and saying that case. In
Yes, sir.
exam, you may not have that liberty.
Yes, sir.
Yeah, we did not have that liberty. So they take your the paper answer sheet where you have written your history, and they will ask you to go ahead. So slowly you start practicing that way also.
Yes, sir.
Then go to the past history also.
Sir, at 12 years of age, he had recurrent episodes of fever with joint pain and sore throat. He was advised to take some injectable medication but didn't comply with the treatment, sir.
Okay. So how will you find out whether that advised medication was, suppose not in this case, any patient, whether it was penicillin or not? How will you find out based on history? If the suppose patient doesn't know the name of the drug, how will you ask in history?
Sir, whether the injection was advised to be taken weekly, on this basis, sir, we can judge.
So
Sometimes
how
even
frequently
B12
to?
can be given weekly. So
Hmm.
that may not be the right way. But what I think Akif is asking is there will be a test dose given always.
Okay,
So
sir.
they will check first whether there was no reaction, then only full dose was given. That is how you can assume that it might be penicillin like that. You should ask that history, right, Akif?
Yeah, yeah. And how frequently do we give penicillin? You said weekly. So
Sir,
normally, how frequently do we give penicillin injections?
sir, we usually give IM injections every 3 to 4 weeks, sir, in 1.2 million internationally.
Okay. So that continues at weekly, no? So
Uh,
don't utter that that
okay,
thing,
sir.
no, weekly.
Okay, sir.
So one is that two things you can ask. One is usually they give test dose and see for any allergy, and that is clearly explained to the patients all the time, most of the times.
Okay, sir.
And the thing is by frequency you can ask once in every 3 weeks and all. And usually they that time whenever they give, no, they either explain to the parents or somebody that how long the patient may need to take injections and also. So you can ask that in history also.
Okay, sir.
So suppose you want to know whether it was penicillin or not.
Okay, sir.
Okay, so smoker. Okay. So yeah, next go keep going. Family history next. Okay, so now coming to your differences. So now what do you
So,
think? Now after the discussion, what do you think the first differential could be for this patient?
Sir, first differential would be valvular heart disease, likely the mitral regurgitation.
Metal regurgitation. Okay. The
can't it be
history is not mentioned, na?
COPD?
Sir, sorry, sir.
Hello?
Sorry, sir.
Can't it be COPD?
Sir, it can be COPD, sir. But since there was no past history of any respiratory distress prior, so therefore it is unlikely.
So your
Only
what I wanted to ask was your DDs are very specific.
Sir,
You have directly written like valvular heart disease, even MR somewhere you written specifically that it is mitral regurgitation. Your DD at the end of history does not need to be so specific. They will end up saying that you already know your case, that's why you are writing like this.
okay, sir.
So maybe at the end of history, what you can conclude is based on history, because shortness of breath came first, and then it may be a cardiac disease with, like Akif asked initially, whether it can be stenotic lesion or MR lesion. Based on the history that shortness of breath started early and then palpitation came, so maybe it can be a stenotic lesion, but I would like to confirm on examination. So don't give specific diagnosis at the end of history, keep it open. You may be wrong, but based on your history, your DDs should be right based on your history. Then, after examination, you may change your diagnosis. That is okay. Okay, so don't give very specific diagnosis like this,
Yes,
and
sir.
just try to keep it broad and open.
Yes, sir.
and Aditya, what is the most common cause of breathlessness in
Sir,
overall? What is the most common cause of breathlessness?
wha- sir, it can be due to anemia, sir, or it can be due to anxiety, sir. These are
Correct.
the
So can't this be
Yeah.
anemia?
sir, anemia. It can be, but sir, since there is history of fever and the progression is since 5 to 6 months, sir. Therefore, sir, unlikely
The
to
So
be,
point
anemia.
is, don't get stuck to
Anyway,
one diagnosis of heart or something.
sir.
Just keep your differential diagnosis open and wide. Okay, at the end of history.
so anemia can also progress, na? Over 6 months, it can
Yes, sir.
progress. Patient can have palpitation, and patient after slowly he can develop heart failure. Also, he can have PND or orthopnea. Also, that's
Yes, sir.
also a possibility.
Yes, sir.
Fever is, for your case, fever is, I think it's not related to that only because it has not precipitated anything.
Yes, sir.
So don't you think anemia can be a possibility or no?
Sir, it can be a
Based on
possibility.
history, I am asking clear.
Yes, sir.
It can be a possibility.
It can be a possibility.
Yeah, that could have been in your top also. One of the top differential diagnosis in this case because all the pictures fit into that. Okay. So why you said congenital? You secondly you said congenital heart disease. Which congenital heart disease present in 58 years of age?
Sir, it can be a cyanotic heart disease like ASD, PSD, or sir, PDA.
Okay. So VSD present till this age, 58 years of age.
Sir, I'm not sure.
So they are very
Yeah, but
uncommon. No?
if you
Age is
keep such
58.
differential diagnosis, definitely your Viva will go to that level. So if you have written CHD at second differential or even dilated cardiomyopathy as third, you
Yes,
should
sir.
be ready to give answer why it is it or why it is not. In both ways, you should be able to answer it. So if you want your Viva to go in that direction, definitely write it. But otherwise, avoid using such terms.
Okay, sir.
Okay. Better way is let them ask whether it can happen like this or not. That is the better way of doing it.
Yes, sir.
Because 58, na? Usually 58 age, any congenital heart disease stable till then and presenting at 50 age is very unlikely.
Yes, sir.
As you rightly said, ASD can be a possibility, but that also usually, if it is there, usually presents from fourth to fifth decade only. Okay, so it's almost sixth decade of life. It's very unlikely. And as sir said, no, because you have mentioned second, no, your driver can only go towards congenital heart disease only. Then they may ask you anything in congenital heart disease.
Yes, sir.
Okay, so don't keep that diagnosis, which is very uncommon. I don't think it should be your second diagnosis.
Yes, sir.
I think it should not be in your top six also. It should be very much last or only. Okay. Okay. And next you said which one? Dilated cardiomyopathy.
Sir,
Okay. So it can be dilated cardiomyopathy.
sir, it can be a post-viral myocarditis, sir. So I have put that.
Okay. The post-viral your fever is now only, no? It was not
Yes,
there
sir.
6 months back. So again, still it's unlikely. Yeah, normal dilated cardiomyopathy can present at this age. That's a possibility. But don't tell like this, no? Because of fever now it has COVID. Because your symptoms is from 6 months, no, you're saying.
Yes, sir.
So
Symptoms.
suppose the fever was there at that time and patient has developed restlessness and ongoing was there, then it could have been myocarditis.
Yes,
The
sir.
persistent myocarditis there. But now it can be a normal dilated cardiomyopathy, which is likely because patients sometimes present at this age also. Okay. So that you said what infective endocarditis next. Okay.
Just 1 second. So at the end of history, most common should be your differential diagnosis.
Sir.
If you dilated cardiomyopathy is not you cannot decide dilated cardiomyopathy based on your history.
Yes, sir.
So things that cannot be decided based on history should not be your differential diagnosis.
Okay, sir.
Okay, if you are able to tell based on history that it definitely can be dilated cardiomyopathy, I want to confirm on examination, then it's okay. Can you do that? Is this history specific for dilated cardiomyopathy?
No, sir.
See, rare causes can be thousands of causes which can be there.
Sir.
That is not the purpose of the examination. You should be able to treat most of the common causes. There you should not make a blunder. So that is what is expected out of you. That much you should know.
Yes, sir.
Okay. So just keep very few simple things in your differential diagnosis.
Yes, sir.
So can this be a pneumonia? Case of pneumonia only.
Yes, sir. Yes, sir. It can be a case of pneumonia.
Okay. So how do you define that? Like,
Sir,
so basically, I'm asking how do you
Things
define
in favor and in
cardiac or
opposite to
pulmonary?
that.
sir, things in favor is the presentation of fever with shortness of breath. But the thing is against is, sir, the shortness of breath was for last 5-6 months, and the fever is of recent onset.
Mhm. And which symptoms comes first in respiratory? Cough comes first or breathlessness comes first?
Sir, cough comes first in respiratory.
In your case, which symptom is first?
The shortness of breath presented.
Yes. So this is there and palpitations. Yes.
Yes, sir.
So it could be, but it's unlikely. Based on your history, it goes more towards cardiac when compared to pulmonary.
Yes, sir.
So that's okay.
So based on your history, I think at the end of summary, what you should say is,
Sir.
I think, because of shortness of breath, it can be a cardiac or respiratory cause. More likely a cardiac cause because of these things.
Yes, sir.
And in cardiac, one of the few DDs you can give, like it can be valvular or something, 2 or 3 DDs like that, no specific diagnosis. And then you should say, I would like to examine and decide further later. Yes.
Okay, sir.
Okay.
Okay, sir.
And I think your case maybe I think it's infective endocarditis or something. That's why you're stuck in fever. No? You're saying everywhere fever.
Yes, sir.
Yeah, so
So I
then
think
what will definitely they will tell you at the end that you already knew your case was IE. That's why you were going like this. You can never diagnose infective endocarditis only based on history again.
Yes,
You
sir.
can just say whether it is cardiac or respiratory, or it can be stenotic or regurgitant, or it can be ischemic, something like that. This much only you can say based on history, and don't go in much details of anything. Keep it open.
Yes, sir.
Okay. Maybe we can go ahead, Akif.
Yes.
So this is very important. Just everybody who is listening, summary should be crisp, and your differential diagnosis should be based on your history. It can definitely change later on, but it should explain your history, what you are saying, and it should be very. I would keep it very wide and open so that you can put anything which comes later on in your DDs like that. Okay,
Yes, yes,
don't give specific diagnosis. Go on.
Yeah. And one more thing I'll tell. One last thing.
sir.
And don't use the short forms. You said PND in your summary, no?
Yes, sir.
So never use short forms in your exam, no?
Okay, sir.
Okay. So always say complete full paroxysmal nocturnal dyspnea. Don't say NYHA also. Always say New York Heart Association.
Okay, sir.
Okay. So don't use short forms. So if your examiner doesn't like using short forms.
Okay, sir.
Okay. And you know what is New York Heart Association grading? You know what is the definition in its grading in exact terminologies? You know.
Yes, sir.
Yeah.
What are those? What is NYHA 1, 2, 3, 4?
Sir, this is the sir. So these are defined on the basis of the cardiac symptoms, sir. Grade 1 is asymptomatic patient at rest. The grade 2 is the patient is asymptomatic at rest, but there is a dyspnea with the ordinary physical activities, day-to-day activities, sir. On grade 3, the patient remains asymptomatic at rest, but there is limitation of his physical activities, sir. He performs less than ordinary activities, sir. In grade 4, the shortness of breath is present even on the rest, sir.
Okay, frankly, I am not sure, but you just read it up properly and make sure that you say it like a rattafa. You know everything. I mean, you just start saying whenever this question is asked. Okay.
Okay, sir.
Okay, go ahead with general
Yeah.
examination.
More important, there in NYHA, always say that patient with cardiac condition, and then you say grade 1, grade 2, grade 3.
Yes, sir.
So many examiners are very fond of listening to that line, patient with cardiac condition, and then you go ordinary limitation to ordinary activity, and so on, all this.
Yes, sir.
So for everybody else also, if anybody asks you NYHA, always say patients with cardiac condition, then you state as class 1, class 2, class 3, class 4. So that line is very important. Yeah, you can continue with general examination.
On general examination, at the time of examination, the patient was sitting in propped up position on the bed. He was conscious, cooperative, and following commands. On vitals, he was febrile with 101 fever. Pulse was 122 beats per minute, irregular. In the right arm, and on examination, the pulse apex deficit was more than 10 beats per minute. Blood pressure was taken in the right arm in the supine. It was 100 by 60, and on repeating it, it was 102 by 64. And in left arm supine, it was 98 by 62. Respiratory rate was 24 per minute. On head to toe examination, there was pallor, but icterus, clubbing, cyanosis, lymphadenopathy, and edema were absent. On further examination, small tender nodules were seen on the skin of the fingers and toes. There were no features suggesting of arthralgia, dyslipidemia, etc. On cardiovascular examination, on inspection,
What are the features of dyslipidemia?
sir, xanthomas like present over the eyelids, medial border of the eyelids, sir. There can be, sir, skin tags. There can be signs of insulin resistance like acanthosis nigrans on the back of the neck, sir. And, sir,
So, but why did you say dyslipidemia?
sir,
You have said atherosclerosis. Why did you mention specifically dyslipidemia? You have said signs of atherosclerosis, maybe. So that would have been better.
okay, sir.
Why specifically dyslipidemia? There are only pertaining to dyslipidemia, anything like that?
No, sir.
No, because so don't use that term. No? You let's say if you want to say if you're sure about the peripheral signs no, of atherosclerosis and all, it's always peripheral signs of atherosclerosis are not there. You can mention that. Supposing you are expecting that this is a case of ischemia, that ischemic heart disease or anything, then you mentioning these features will be good. The sense of dyslipidemia doesn't sounds good, and I have never heard so far. I have never heard anybody mentioning that peripheral sense of dyslipidemia So that's one thing. And what is apex pulse deficit?
Sir, on measuring the radial pulse and taking the simultaneous auscultating the chest for apex, sir, the apex and the pulse was not matching, and there was a deficit was noted of more than 10 per.
Okay. So that's what I mean. How do you examine that? Deficit was 10 was there. How did you check? You check yourself only? Both things?
No,
Like,
sir.
how did you check?
Sir, I checked the pulse of the patient and simultaneously the I auscultated his apex beat, sir.
So how many were the pulse?
The pulse was 122 beats per minute, sir.
And how many were the apex beat?
Sir, it was around 100.
And you counted both together.
Sir, means someone was counting the pulse and I was auscultating him.
You understood
No,
where you are making the mistake?
Yes, sir.
Yeah. So you should now I'm just telling you, you just read how to measure apex pulse deficit. It is not you one. It is not that the way you said. Okay, there are two ways or three ways actually how you can measure it. Akif, you want to?
yeah, there are three ways actually.
Yeah.
Don't interrupt like this. No, you said you examined first, then you're saying two people checked.
Yes, sir.
Don't do like this. Okay. So see, basically there are three methods of checking apex pulse deficit, and definitely you will be a single one only, no, in exam. So always know the method of single. How do you plan? So one method is like if you are a single examiner who is examining the patient, you should simultaneously check the pulse. Okay, and at the same time you should put a stethoscope on the chest.
Okay, sir.
And it's very impossible to measure count both of them simultaneously. You cannot. Okay. So it's rather than that, it's easier to see the missing beats. Like the number of times you feel the pulse and there is no apex beat, that is much easier to recognize that. Okay, so number of missing beats when compared to the pulse palpation, that is how you calculate the apex pulse deficit. If you are a single examiner, or other method is first you measure the pulse for 1 minute, next minute you measure the apex, like apical beat by stethoscope.
Yes, sir.
So that is the second method. Suppose there are two people are there, then one person can measure the pulse and one other can auscultate and check the apex beat count. So these are the three methods. That's how you say. Okay. So you can get stuck here only. Okay. So what are the other causes where you can get pulse deficit other than atrial fibrillation? Where do you see that?
Sir, it can be seen in supraventricular tachycardia, sir, or extrasystole in premature beats, sir.
Okay. So it's premature beats are more common. Supraventricular tachycardia will not have any difference in that. So there will not be any missed beats in that. It is premature beats actually, premature contractions or VPC, ventricular premature contractions. How do you differentiate then VPCs versus atrial fibrillation based on apex pulse deficit?
Sir, if the deficit is more than 10, then it is atrial fibrillation. If the deficit is less than 10, then it is considered to be premature beats.
Yeah, okay, continue.
And your BP you check in sitting or supine position?
Sir, supine, sir.
Usually.
Supine, sir.
Okay.
What's the ideal method? Ideal method of checking the BP.
Sorry, sir.
What is the ideal method of measuring a BP? Any patient, not in this patient, any patient.
Sir, so the ideal method should be the cough of the blood pressure apparatus, the pressure monitor, and the heart should be at the same level, sir.
Okay. That is one. Any other thing for that? Prerequisite.
Anything before or after?
Sorry, sir.
Yeah. Please read it. It is very important. You are stuck on vitals. So that should not happen. Blood pressure, how to measure blood pressure? It should come out very fast. That patient should not be having caffeine something something. He should be sitting for 10 minutes, whatever you want to say, but it should be to the tip of your tongue. And just read it once, you will always remember it. Okay, but you will need to read it once at least. Okay. How did you look for? What is the grading of pallor? How much pallor did you said pallor is present?
Yes,
How
sir.
much was the pallor?
The pallor was grade 1, sir.
And what is grade one pallor?
Sir, yes, sir, in you, pallor is usually seen in this thing, palpebral conjunctiva, sir, and there should be the two rings of the conjunctiva should be distinctly visible, sir. And if the difference is gone, then that is considered to be grade 1. And in for after that, we measure in the mucosal cavities, that is the tongue and hands. If the pallor if pallor is present in those areas, then it is considered to be grade 2 or 3, sir.
So I think what definitely you can say is only severe pallor versus not severe pallor. So mild to moderate, I think it is very difficult to differentiate when your palms, the deep crease of your palms are also pale in comparison to your this. Then it is deep pallor. Otherwise, it is mild to moderate pallor. There is something like that. So again, read it. How to check for pallor, from where to look for, what all sites you can. Sometimes they will ask, can you check pallor from nail bed? Where all you can look for pallor?
Sir, in the palpebral conjunctiva, in the dorsum surface of the tongue, and in sir palate, and sir also in the nail beds and the palms.
Yeah, so there you should know all this, because if you say one or two, they will say that patient is chewing tobacco, patient is so there is you cannot check dorsum of the tongue. If patient is a farmer and he already has a yellow conjunctiva, so you cannot check pallor from the eyes only. So you should know at least 4 or 5 sites from where you can check for pallor. Okay.
Okay, sir.
Yeah. What is clubbing?
The clubbing is uh, ab- the clubbing is bulging of the nail beds seen in seen due to increased blood flow towards the nail bed, sir.
How do you look for clubbing?
Sir, sir, there is the grading of clubbing, sir, in which first of all there is the loss of the normal angle of the nail beds. After that, there is increased softness of the nail bed. After that, there is drumstick appearance, and after that, there is hypertrophic osteoarthropathy.
So how do you look for clubbing?
Sir, we hold the nail beds with sir. First of all, we take the hands at the level of eyes, and sir, look for the angle of the nail to the nail bed. After that, sir, we put the fingers in between our fingers and check for fluctuation at the nail bed, sir, whether the fluctuation is present or not, sir.
Okay, so this is general examination. It will come in all of your cases. So just read this in detail and just try to mug it up. Okay. So these things you cannot take pauses and just I think once or twice you will read and you will remember it for your life. So that's okay. You just read it in detail and just try to mug it. Okay. Just go upwards. What else was there? Sinuses, pallor, clubbing.
And also remember the definitions proper. Yeah, your clubbing, your definition was not right.
Is bulbous enlargement of phalange.
Yeah. So whatever this 4, 6 things which are there, na, pyloric stress and all, should remember the definition. Because anytime they may ask you definition, and suppose you didn't answer the definition, then you all discussion will be stuck here only.
Okay, sir.
Okay. So as we said, na, yesterday, like in your you should not get stuck at your history and examination part. So if you get
You will
stuck
get
here,
one or
then
two questions only here. If you
yeah,
answer them very quickly and very confidently, your Viva will move ahead very fast. But if you get stuck here, you will get one or two questions only here. but those answers should be very confident and very fast. So for that, you just prepare for that, and then if you pass this, then directly you will go to your cardiovascular examination. Then there are more things that you can. So that is good for you. But those one or two questions should be answered very quickly and very confidently. Okay.
Yes, sir.
You don't want to get stuck here. You want me to ask about small tender nodules seen on the skin of fingers and toes?
Sir,
What are those?
they're likely to be oscillars, sir.
Yeah. So I think Akif, correct me if I'm wrong, that we should keep it as a signs of infective endocarditis in cardiovascular examination, or we keep it in general examination only. I think it's okay to keep it here.
Yeah, it's okay, sir. I think we can keep
Yeah,
this.
it's okay. Okay, go ahead.
But then they'll ask you all this. Remember all the differential diagnosis there.
Yes, sir.
Mention nodules.
Yes, sir.
What are the other causes of nodules which can present there at the fingers and toes?
Sir, it can be seen in EML, sir. Other septic embolic conditions, sir.
ठीक है चलो move your cardiovascular examination.
Okay, sir. Cardiovascular examination on inspection. There was no precordial bulge. Apical pulse was displaced laterally and downwards. Neck veins were engorged. No scar was seen on the chest. No asymmetry was noted on the chest wall, and no visible pulsations were seen over the precordium and the epigastric area. On palpation, trachea was central. Apex beat was hyperdynamic, felt in the fifth and sixth intercostal space on the mid-clavicular line. Parasternal heave was absent. Systolic thrill was palpable at the apex. On auscultation on the mitral area, S1 and S2 were merged within the murmurs. They were not distinctly heard. S3 was present. A pansystolic murmur of grade 4 heard with the diaphragm of the stethoscope, especially when the patient is in the left lateral position and he held his breath in expiration. The murmur was radiating to the left axilla and to the left inferior angle of the scapula. The murmur intensified on hand grip and leg raising. Rest on rest auscultation of rest areas, there was soft S1 was noted and S2 was there. No murmur heard on the carotid auscultation. On respiratory system examination, bilateral infrascapular clefts were present. On abdominal examination, hepatomegaly was seen. Liver was palpable 3 centimeters below the right costal margin. No splenomegaly, no ascites was there. On central nervous system examination, no focal neurological deficit was noted. My provisional diagnosis on the basis of history and examination.
Wait.
Go up.
It is likely a
Go.
No, wait.
Go to
Go to examination, cardiovascular.
cardiovascular. From inspection.
So I'm just asking questions. You may not give answers right away, but you just make sure that you know the answers
sir.
Later on. How to check for apical impulse? From where should you look? Do you want to give answer right now?
Yes, sir. So the patient should be supine, and first we use the palm to exactly feel the.
No, you are inspecting right now. You are not palpating.
Okay, sir. Sir, apical impulse is the outermost and the outermost lowermost part of definite cardiac impulse.
And how do you inspect it?
Sir, I will check. Sir.
Okay, read it. You will get the answer. Read it. Yeah.
Yes, sir. Yes.
Neck veins are engorged. Okay. Liver is also enlarged, but there is no edema, right? Neck veins are engorged, liver is enlarged, but there is no edema. That is what you are saying.
Yes, sir.
How to look for edema?
Sir, we press the medial malleolus for 10 seconds at least, sir.
just make sure that when you are saying this, one thing is there is definitely no edema because they will definitely check. And if there is edema and you have mentioned there is no edema, then you are stuck. Okay. So when your history examination are not corroborating with each other or your examination findings, make sure that whatever you are saying, that is not the way that you should say edema when you are saying other two things and there is no edema. That is also wrong. If there is no edema, you just say that maybe he has taken diuretics, maybe whatever happened. So there is no edema right now. But your examination findings should not be wrong. Okay. So there are engorged neck veins. Okay. No scar, no asymmetry, no visible pulsations. Okay. Anything in inspection, Akif?
JVP you didn't mention.
Sir, I only saw the sir neck veins since he was in AF, sir. I wasn't able to make out for the JVP, sir.
Yeah, that's okay. But you should mention your cases.
Okay, sir.
If you're not visible, that's fine. Because of many reasons, it could not be visible. That's okay. You should mention. And cardiology examination always start with examination of the neck first, and then you go to the chest.
Okay, sir.
So this engorged veins you can mention there. So first start with examination of the neck. To tell about JVP, if any engorged veins are visible or any scars or anything. So mention about the neck, and then you go to the chest. Inspection part was okay. Palpation, you said apex beat was, you said two intercostal space. You felt it in two intercostal space.
Yes, sir.
Fifth and sixth, you said.
Yes, sir.
So what do you
And that
think
is
it
in
is?
the mid-clavicular line.
Sir, on the mid-clavicular line.
It is not outside, no?
Sir, on the mid-clavicular line, not beyond that, sir.
Okay. And how? Akif, you want to ask more about? Or otherwise, next question is personally how to look.
What do you think it is? You said two intercostal space. You felt the apex beat.
Yes, sir.
So is it right ventricular apex or left ventricular apex?
Sir, it is likely a right. Sir, likely a right ventricular.
Okay. So why do you think that? So anything you answer, you should know. We'll ask you why. Why do you think it is right ventricular? Or otherwise, how do you differentiate whether it is right ventricular apex or left ventricular apex?
Sir, on
How
the
do you differentiate on examination?
Sir, on the basis of synchronous with the apex beat, sir. If the pulsation is synchronized with the apex beat, then it is likely, sir, left side. If it is not synchronized with that, then it is likely to be right side, sir.
No, you are talking about apex bit only. No? How can you check synchronous of apex bit with apex bit?
Sir, for right side and
So it's basically not like that. Okay, so see, in left ventricle, if we feel apex beat, you will feel only one thing, whether it would be right ventricle or left ventricle. So supposing if it is only left ventricle, usually during left ventricular apex, whenever it is felt, only the apex part of the left ventricle is touched to the chest wall, not the entire left ventricle. Okay, so usually left ventricular apex is usually localized, single point. Okay, right ventricular apex, genuinely feel that whenever there is right ventricular enlargement or hypertrophy due to any reason, the whole right ventricular will shift towards the chest wall. So the whole wall of the lateral wall of the right ventricle will be towards the chest wall. And there will be diffuse palpation. You may not feel it at a single place.
yes, sir.
So here, usually two intercostal space left ventricular apex is not felt like that. If you're saying like that, I am assuming it is right ventricular apex based on what you're saying. So what do you think? It's left ventricular or right ventricular apex now?
Sir, likely right. Sir.
Right ventricular. Okay. So any epigastric pulsation you felt?
Sir, no epigastric pulse, sir.
Supposing this patient had an epigastric pulsation, so what do you think then it would be?
Sir, it could be due to abdominal aorta, sir, or it could be due to right ventricular impulse, or it could be a hepatic pulse.
You know how to differentiate it differentiate between these three based on palpation.
Yes, sir. If the impulse pushes downward, then it is the right ventricular impulse, sir. If the impulse strike the pulp or the palm, then it is likely to be abdominal aorta, sir. And if the impulse is felt on the right side of the finger, then it is likely to be hepatic pulse.
Okay. So you didn't feel any epigastric pulsation?
No, sir.
Okay. You still want to think it is right ventricular apex only?
I will check.
See, purpose of today's is to know maximum questions, and when you go back, you read about answers and make sure that you don't make mistakes again. So it's okay, but just understand how things will go in the exam. Okay.
Yes, sir.
How did you check for parasternal heave?
Sir, we put the ulnar aspect of the hand towards. We usually use the ulnar aspect of the hand.
Just you should know the answer. It's okay. Yeah. You didn't do percussion?
Sir, percussion, sir, to be done only for cardiac border judgment if we are unable to palpate the apex beat or there is discrepancy in the findings, sir. And in this case, if there is likely infective endocarditis, then there is a chance of dislodgement of the embolus. So that is why percussion.
Okay. ऐसा है क्या आकिफ? I mean, I don't know. We have stopped doing percussion now.
Yeah. So no, many of them now say don't. Percussion is not there in routinely, it's not there. But for you, for general medicine, it has to be mentioned.
Okay, sir.
So for cardiology, for us, we used to say at AM level, percussion is only if required, only if they indicated, then only we should do. Otherwise, we will not do it. Okay. And you sure on percussion it gets dislodged normally the vegetation and all?
Sir, I will check it, sir.
I think you should do percussion gently then.
So no, see, usually percussion is not contraindicated. So generally, contraindication is said for what when you have to give a shock to a patient, suppose for some other reason, cardioversion wave. So then definitely we look for clot or anything is present that may get dislodged. But usually normal percussion should not get dislodged. In that case, patient should not walk also. Any movement can dislodge. And I'm just saying, not to demotivate you, I'm just saying this. Percussion does not do that. You have to mention percussion.
Yes, sir.
So even though if it's not required also, you might have got all the picture based on the palpation, auscultation, and but still you have to mention percussion. At least the otherwise, how do you mention all? How do you do percussion? Process of percussion.
I will.
Since you missed it, na? Since you didn't write it, this has made us more interested in asking you questions on percussion.
Sir, I will check.
Oh, how do you do cardiac percussion?
Sir, I will check, sir.
Okay. Yeah. Okay. Please check. Auscultation.
Sir,
So I think what I would do is you are first mentioning S1, S2 merge with murmur, and then you are talking about the murmur. I think if it is like pansystolic murmur, I think it's okay to mention it first. No, don't need to go in such sequence only. A pansystolic murmur of grade 4. What is grade 4?
sir, the murmurs are classified. Murmur grades are classified on the sixth grade, sir. Grade 1, 2, 3 are usually grade 1 is barely audible, sir. Grade 2 is audible, but it is soft. Grade 3 is, sir, easily audible, and grade 4 is audible. Grade 4, 5, 6 are audible and are associated with a thrill, sir.
So there is no difference between 4, 5, and 6.
No, sir. Sir, in 6, we don't even need a stethoscope for the murmur, and sir, in 6 there is just on pressing lightly we can auscultate the murmur, sir.
It would, whether it would have been a mid diastolic murmur, then also you would have given the same grading.
No, sir. This is only for sir systolic grading. Systolic.
Okay.
And what you said about S1, S2 and mitral area was not heard. You said, or
Sir, it could not be appreciated, sir, due to the nature of the murmur, sir.
okay. You can say like that, but you didn't mention like that. Usually, what you read S1 2 were merged within the murmur. It doesn't happen like that. Then it is a continuous murmur.
Yes, sir.
You will be able to hear S1. So you can say it is not appreciated because of the murmur, that is okay. But it is merged within the murmur, that means the murmur is continuous. So it is not letting S1, S2 to be recognized.
Okay,
So
sir.
pansystolic murmur is not like that. What you have mentioned is for continuous murmur. And what did you say? Pansystolic murmur.
Can you draw this murmur?
I want to ask in
Sorry, sir.
Can you draw this murmur?
Yes, sir.
Yeah, so just make sure that you have already drawn it on your answer sheet before the Viva starts, because many of them would like to see how do you do it. Okay,
Okay, sir.
so you must always know how to draw your murmur, which you are able to hear. S1, the relation with S1, S2, intensity, everything should be shown in that figure. Okay.
Yes, sir.
Yeah, Akif, you are saying something?
Hello, sir. I'm Dr. Neeraj.
Yes, doctor.
So, so any other causes that you can hear pansystolic murmurs, other differentials? Did you think of any dynamic auscultation here?
Sir, I will check, sir.
So what are the causes of pansystolic murmur? DD.
Sir, it could be due to MR, it could be due to sir, tricuspid regurgitation, could be due to ventricle septal defect.
That is where you want to do dynamic, that you have already done, I guess. Intensified on hand grip and leg raising, no?
Yeah, yes, sir. Yes.
Mhm. So any murmur that whenever asked, you should try to say at least 3, 4, 5 DDs immediately. What are the causes of pansystolic murmur and mid diastolic murmur, whatever it is, you should give 4, 5 DDs immediately. Okay?
Yes, sir.
No, in mitral regurgitation case, why do we do dynamic auscultation? You have mentioned here, no? 2 points you have mentioned. It was intensified on hand grip and leg raising.
Sir, to grade the severity, sir.
So you have already graded, no? It's release there, everything is there. Why do you want to do then dynamic auscultation in this patient? There's a specific reason. In this specific case, you have done dynamic auscultation. There should be some reason for that.
Sir, to differentiate it from the regurgitation of VSD and PT.
Okay, that you can differentiate by hand. By hand grip, if you do hand grip, you can differentiate it from VSD, like from VSD, MR, and TR. Can you differentiate only based on hand grip and leg raise? Okay. And usually dynamic auscultation is not used to differentiate it for TR, MR, and VSD. It's basically in mitral regurgitation, you do it because you want to differentiate it from mitral valve prolapse. So mitral valve prolapse, no, you know, no, mitral valve prolapse. One condition is can your case be mitral valve prolapse based on your history from everything? Can it be mitral valve prolapse?
Sir, if sir, it can be a mitral valve prolapse, but there should be specific findings for that, sir, like clicks should be there, sir.
Where do you hear the click? In which phase of the cycle?
Sir,
Cardiac cycle.
Sir, in systolic, sir.
Systolic. Okay. So suppose then based on dynamic auscultation, click may not be here in all the cases. May not be here also. But based on dynamic auscultation, how do you differentiate mitral valve prolapse with a normal MRI, like
Sir,
primary MRI?
Sir, in mitral valve prolapse, the sequence is reversed, sir. The murmur of mitral valve prolapse usually decreases with the hand grips.
Okay. And you know mechanism, why does it happen, that pathophysiology beyond that?
Sir, I will check, sir.
Yeah. Okay. So it's important. So always remember, when in any case of MR, for everybody I'm saying, so any case of MR, you have to mention dynamic auscultation. That is compulsory in mitral regurgitation and in aortic stenosis.
Yes, sir.
Okay, where in aortic stenosis you want to differentiate it from HOCM because both are left ventricular outflow tract obstructions. So there, to differentiate between AS and HOCM, we have to do dynamic auscultation. Here, to differentiate from mitral valve prolapse and mitral regurgitation, means primary mitral regurgitation,
Yes,
you
sir.
have to do dynamic auscultation. And there is specific mechanism also. Many examiners are very interested in asking dynamic auscultation. So what happens? Why does MVP and HOCM behaves differently from all the other markers? Okay. So explaining this will may take more time, but write that question. You read that down.
Yes, sir.
Pathophysiology of MVP and HOCM. Why does the murmur increases in standing position in those patients? What does it happen? Okay. 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 So next. And you said on examination, gastro examination, you said hepatomegaly was there, no?
Yes, sir.
Okay. So what do you think? Why hepatomegaly was there in this case?
Sir, it is likely due to the, sir, backflow.
You mean to say congestive hepatomegaly?
Yes, sir, congestive edema.
Pedal edema, you said was present, absent?
No, sir, pedal edema was not there at that time of exam.
Oh. And JVP also did mention. So can a cardiac patient present with only with hepatomegaly without pedal edema and raised JVP?
Sir, I will check.
Yeah. There is one diagnosis. Okay. Constrictive pericarditis can present like that.
Okay, sir.
Okay. Only in constrictive pericarditis in cardiac condition, where patient can present with early hepatomegaly without pedal edema and all. But otherwise, in all usually can be, see, atypicals can always be there, but usually pedal edema and elevated JVP always be there. Okay, and for the right heart failure to develop, no, it should have also would have tricuspid regurgitation murmur or right ventricular enlargement. Then parasternal heave, everything should have been present in this case.
Yes, sir.
So it doesn't fit into your examination and history, right? Or it could, can it be because of your infective endocarditis? You're saying infective endocarditis is there. From starting, you're saying infective endocarditis. Can it be there? Hepatomegaly in that?
Sir, it can be there.
So supposing it is congestive, you're saying congestive hepatomegaly, will it be painless or painful?
It would be painful, sir.
So here you didn't mention, right? It was painless or no, you didn't mention.
Not mentioned.
So that also has to be mentioned.
Yes, sir. Yes.
And suppose JVP was not visible, prominent, then if in your case you are saying suspecting congestive hepatomegaly, then you could have also done abdominal jugular reflex.
Yes, sir.
You know how to do abdominal jugular reflex?
Yes, sir.
Can you tell now?
Sir, the patient is made. Sir, first of all, the position of the patient should be inclined almost 30 to 45 degree. And sir, then after that, we will look for the towards the right neck for internal jugular pulsation, sir. After that, a steady pressure is applied over the right upper quadrant, and then the jugular vein is observed, sir.
So how long should you put compression, and after compression, for how much duration you should watch for?
So after for almost 10 to 15 seconds, sir. And there should be engorgement.
Even after removing the pressure also, the engorgement should be persistent.
Yes, sir.
Okay, so read about that also. No? Hepatojugular
Yes,
reflex also
yes, sir.
important. Not for you, for every examination. You read about that. Is there anything else you want to add, Dr. Nirens?
I think that should be, sir. We should, I think, discuss about the final diagnosis maybe.
Yeah, Aditya, continue. Go for your
Go
final
ahead, tell
diagnosis.
us the diagnosis.
Sir, this is likely a patient of acquired valvular heart disease, likely in the form of chronic mitral regurgitation of rheumatic etiology with possible atrial fibrillation with left ventricular dysfunction and with features of infective endocarditis. And the patient is currently in class 4 New York Heart Association.
So here first, I want to ask, why did you tell this is chronic mitral regurgitation? So can there be mitral stenosis part to it, and why atrial fibrillation and not simply is it volumogenic arrhythmic attacks that he is having, or is it arrhythmogenic that we see in atrial fibrillation that he was having?
Sir, I will check, sir.
It's not to check. I think you should stand for your diagnosis. Why you have written that? You should give your versions why you have written.
Sir, since in the early childhood, he was diagnosed as likely a case of rheumatic heart disease, since he was advised injection, but he wasn't able to take it. So therefore, some valvular disease was there. Therefore, I am saying chronic MR.
Okay, so chronic MR developing into atrial fibrillation, how common is it?
Sir, I exactly don't know, but I will check, sir.
Akif sir, are you happy with it? You want to?
Yeah, and you didn't mention about this severity of mitral regurgitation. You did say. Actually, acute or chronic, then if you don't mention, that's fine, but you should label it as either mild, moderate, severe. Based on a clinical examination, you should come to a diagnosis.
It is likely severe MR, sir.
So how do you say it is severe mitral regurgitation? Clinically?
So because the patient, on the basis of history, the patient was having orthopnea and PND, along with that grade 4 NYHA shortness of breath.
Okay, clinical examination. Leave of history. Clinical examination. How do you say?
Sir, since the pansystolic murmur was heard and there was S3 gallop present.
Okay. So S3 is correct. Pansystolic may not be. Any MR will have pansystolic. Any other thing you mentioned? One is S3 you mentioned. Other thing should be your thrill. No? You mentioned thrill is there.
Yes, sir.
So thrill itself denotes that it is a severe mitral regurgitation. There are two more things in mitral regurgitation to label. One is the deviation amount of LVH which is present. So generally, if the MR is very severe, there will be severe enlargement of the left ventricle, and usually the left ventricle will be more outwards and more downwards. Which in your case it was not much. I think it was only marginal only. No? It was in 5th or 6th intercostal only in the mid-clavicular lines.
Yes, sir.
And the other thing is the mid-diastolic murmur. Sometimes because of the severity of regurgitation, the blood again goes to left atrium, and there will be a flow murmur between the left atrium and left ventricle.
Yes, sir.
That is mid-diastolic murmur will be heard, and that functional murmur itself denotes that it is a severe mitral regurgitation.
Severe.
And you know the physiology of S3 and S4, no? You mentioned S3, no? So they'll ask you.
Yes, sir. Yes, sir.
So not going into much details, we discuss more of management now. But read about that. S3, S4.
Yes,
Suddenly your whole discussion can be only on S3 and S4.
Yes, sir.
So read about why it happens, what are the causes of S3, S4, physiological causes, pathological causes. You should be aware of all.
Yes, sir.
Okay. And one thing which was missing in your diagnosis was you didn't mention about pulmonary venous and arterial hypertension. You didn't mention.
Yes, sir. I will mention it, sir.
So is it there now? Based on your examination and everything, do you think patient has pulmonary venous or any arterial hypertension?
Yes, sir. He is likely having, sir, pulmonary venous hypertension
Venous hypertension. Okay. How did you say that?
because he was having cough with pink frothy sputum.
Okay. So pulmonary edema picture is.
Yes, sir.
Okay. Pulmonary arterial hypertension is there or is not?
Sir, don't know, sir.
Basically, I want to ask how do you assess PAH clinically? I am asking. Pulmonary arterial hypertension clinically, how do you check for what all you check for pulmonary arterial hypertension on clinical examination?
I will read about it.
Okay, so basically all the features of right ventricular enlargement. Suppose there is severe pulmonary hypertension, you will have a loud P2,
Yes, sir.
a palpable P2 will be there, loud H2 will be there, right ventricular enlargement will be there.
Yes, sir.
So which you are saying fifth and sixth both your right ventricular hypertrophy you are feeling that will be there.
Yes, sir.
Epigastric pulsations will be there. A tricuspid regurgitation will be there.
Yes, sir.
Okay. So you're saying your final diagnosis is severe mitral regurgitation due to infective endocarditis and underlying rheumatic heart disease.
Yes, sir.
Okay. So now how will you like to evaluate this patient?
Sir, first of all, I will get all the basic baseline investigation like CBC, renal function, liver function. It's to be done. In CBC, we can get low hemoglobin, and in along with that, we can get high TLC likely due to infection. After that, there can be transaminitis due to hepatomegaly or congestive hepatomegaly. There can be renal dysfunction likely due to decreased cardiac output. After that, sir, I will get ECG and chest X-ray done. In ECG, there will be signs of AF with irregularly regular R interval. Along with that, there can be signs of left atrial enlargement like P mitral. After that, sir, in X-ray, there can be signs and symptoms of pulmonary congestion. Along with that, there can be pulmonary edema can also be seen, sir. After that, I will get the blood culture in 3 different bottles from 3 different sites for starting, and after that, I will start empirical antibiotics, sir.
So we'll go one by one again. Okay. So blood investigations you said. So hemoglobin. You said. Okay. So you expect any change in hemoglobin in this patient? Like each investigation, there should be some reason
Yes,
why
sir.
you are doing specifically.
Sir,
So what exactly do you want to see in CBC? Only discuss about CBC.
there will be low hemoglobin. There can be raised total leukocyte count with neutrophilic leukocytosis. Along with that, there will be toxic granules in the general blood picture, sir.
Which granules?
The toxic granules, sir.
Okay. Okay. So you can have anemia. Okay, that's fine.
Yes, sir.
You can have raised WBC count because you're expecting infective endocarditis. Anything else you want to look in blood investigation?
But in
So it can be rheumatic fever flare also. That time you want to do any investigation specifically to that.
sir, I will read about it.
So check both. Since it's a cardiac case, so they may also ask you the modified Jones criteria for rheumatic fever and Duke's criteria for infective endocarditis.
Yes,
Your
sir.
case has both.
Yes, sir.
They can also ask you about the blood cultures, how to collect the blood cultures,
Yes, sir.
how many samples should be taken. So you can discussion can go in both directions, rheumatic fever and infective endocarditis.
Yes, sir.
So read about both of them properly. Basically, the score and the management part. Especially the score, they will be asking. Definitely, they will ask the Jones criteria. So I'm assuming you are aware of that.
Yes, sir.
Jones criteria, read that. And you said next you said was transaminase. So elevation of transaminase. That you are suspecting because of congestive
Congestive
cardiac.
hepatitis. Yes, sir.
So how high it will be in congestive cardiac? Hepatopathy, congestive hepatopathy.
Sir,
In congestive hepatopathy, how high?
sir, it can be in hundreds, sir.
Only in hundreds. That's all.
No, sir, hundreds and even thousands, sir. 1,000, 2,000, sir.
So that's what are the causes of cardiac hepatic diseases where the transaminase are more than 1,000?
Sir, in sir, congestive hepatitis, along with that, sir, ischemic hepatitis, there is any acute MI, sir. After that, there is LV dysfunction that can lead to raising of.
Again, you're saying the same thing, congestive.
Along with that, sir, acute.
So one is congestive hepatopathy, ischemic hepatitis, viral hepatitis, and drug-induced or toxin-induced hepatitis. These are the four causes where transaminase are more than 1,000.
Okay, sir.
Then you said ECG. So ECG, assuming because your pulse, patient pulse is irregularly affected, so they are assuming it is atrial fibrillation. So in ECG, how do you diagnose atrial fibrillation?
Sir, there will be absent P wave, narrow QRS complex, and the rate should be more than 120.
Then you said you will see P mitral here. P waves are absent.
Yes, sir.
So don't make that mistake.
Yeah.
Just to bring to your notice, that's why I said it. So I don't know for your level they'll ask or not. Sometimes it is also asked. Supposing a patient is having atrial fibrillation.
Yes, sir.
So in ECG, how do you diagnose left atrial aneurysm?
Don't know, sir.
Is that write down this question?
Yes, sir.
This will be like if you are doing very well, extraordinarily well for the bonus to get distinction, this question will be asked. Okay. So one thing is fibrillatory wave. Okay. So there is something called fibrillatory wave. You know that F wave or fibrillatory wave.
Sir, I will read.
Yeah, read it. Okay. Normally in lead B1 of atrial fibrillation patients, in the ECG of B1 is there, you will be able to see fibrillatory waves. So like there will be multiple small P waves like fibrillatory is called F wave. So based on the size of the F wave, we can decide if it is the F wave is more than 0.5 millimeters or more. Then it is usually they say that if it is more than 0.5 millimeters, then it means there is left atrial aneurysm.
Okay, sir.
So I'll send you that ECG. I'll send that in the group. Everyone can see later.
Okay.
Fibrillatory wave. Okay. So any ECG, you will be having spotters as any ECG. So always remember, how do you describe any ECG?
Sir,
Not just any suppository ECG.
sir, rate, rhythm, axis, then P wave, QRS complex, ST segment, and sir, after
Before all this, what is the first thing you should see in any ECG?
that, standardization, sir.
Okay. So what what is standard ECG?
Yes, sir. Sir, paper speed should be 25 millimeter per second, and the voltage should be 10 millivolts, sir.
No. Yeah. 1 millivolt should be 10 millimeters.
Okay, sir.
Yeah. So paper speed you said right. Yeah. That's very important. Huh?
Yes, sir.
Not for this case, for any case, always remember when your exam, if they give you any ECG for interpretation, always check the speed first and then look for the voltage. Okay. 10 millimeters should be equal to 1 millivolt. This is mentioned in the ECG.
Okay, sir.
Suppose this is not mentioned, at the end of the ECG, you will have a bar diagram, bar will be there.
Yes, sir.
Bar image will be there. That image should be consisting of 10 small squares or
Yes,
2
sir.
large boxes.
Yes, sir. Yeah.
That also indicates the standard ECG.
Standard.
So in this patient, what will you expect? Chest X-ray changes? This is mitral regurgitation. You expect any changes in chest X-ray?
There will be, sir, cardiomegaly, sir. And sir, there will be signs of left atrial enlargement, like there will be straightening of the left heart border, and there will be splaying of carina, sir. And sir, there will be, sir, signs of pulmonary venous congestion, like prominent upper lobe veins, that is cephalization. And sir, along with that, there will be curly B lines.
You will see the straightening of left heart border. You really see it in mitral regurgitation.
Sorry, sir.
You said the straightening of left heart border. You see.
Yes, sir.
So is it there in mitral regurgitation or mitral stenosis?
It is more commonly seen in mitral stenosis.
Okay. And also the patient should have pulmonary artery hypertension for you to have a proper straightening of left heart border, mitralization.
Sir.
So for that to happen, you should have your left atrial appendage should be enlarged, pulmonary artery should be very prominent pulmonary areas. So all these things should be there. And you know how to describe a chest X-ray, no? Read about that also.
Yes, sir. Yes, sir.
So if they give you any X-ray, no, don't rush to diagnosis directly.
Yes.
Follow a proper chest X-ray, APView, PAView,
Yes, sir.
inspiratory film or expiratory film exposure.
Yes, sir.
So everything is important. Always follow the basic details. That is very important.
Yes, sir.
So after the X-ray, what else do you want to do in this patient?
Sir, 2D echo, sir.
So what do you want to see?
Sir, to look out for
Sorry.
any vegetations, along with that systolic LV function, and whether there is dilatation of chambers or not. And sir, the orifice area, the regurgitant volume and regurgitant fraction, sir.
Fine. Then how will you manage this case? Supposing this patient has, you have diagnosed mitral regurgitation is there. You have seen the vegetation also. So how will you manage this?
Sir,
Treatment part.
Sir, first of all, we will start empirical antibiotics. Sir, along with that, sir, we will start diuretics for decongestion to relieve the symptoms, sir. Sir, if the patient is currently in the heart failure, then we will consider starting the fourth pillar, that is beta blocker, RNEs, SGLT2 inhibitors, and sir, MRA, sir, mineralocorticoid receptor agonist, sir.
Okay. So these are started in acute heart failure or chronic heart failure?
Sir, these are for chronic heart failure.
They can ask you also. I don't know whether they'll ask. I don't think trials they will ask you, but all these drugs definitely. Said titanium stent or heart failure remodeling drugs.
Yes, sir.
Diuretics you said, effective antibiotics. I'm assuming you know the treatment of effective antibiotics.
Yes, sir.
When you said empirical antibiotics, they ask you what antibiotic, dosages, duration of therapy, how long you have to leave.
Sir, 4 weeks after the first negative culture, sir. At least 4 weeks.
At least 4 weeks after the first negative.
Yes, sir.
And you are aware of oral therapy for effective antibiotics?
Sir, I am not aware of, sir.
Recently, last year something one trial, POET trial. I don't know if you are aware of POET trial is there.
Okay, sir.
So they can ask about oral therapy also. It's coming into the picture now. The oral therapy after stabilizing the patient for 10 days with IV antibiotics. So we can also try for oral therapy. Sir, you want to add something, Dr. Nirin, sir, Dr. Dilip?
Yeah, I think this should be fine. So they should know the empirical antibiotics for infective endocarditis. How will you diagnose the criteria? So the due criteria also has been recently modified. They included many things and removed some of the things, especially the timing between two positive blood cultures. So I think you should go look for the new criteria, IVSCLD criteria as well, and know the empirical antibiotic choice and how will you. So also one important thing is when is surgical intervention required in infective endocarditis. So can you know some of the indications where surgery is required?
Sir, when there is severe symptomatic mitral regurgitation, and if the patient is asymptomatic, but the definite indication is uh, the grade 4 NYHA, and along with that severe MR, there, if there is uncontrolled infection that is persistent bacteremia with.
Yeah, okay. So based on etiology, there are some like for fungal endocarditis are difficult to treat. And next important comes the embolic phenomena. So if it is very large vegetation that is about to embolize, so more than 2 centimeters becomes an indication. But if it is 1 centimeter also, and if there is embolic phenomena, also it is an indication. So as such, the mortality is very high with infective endocarditis. So, but early surgery might help in those kinds of patients. Okay.
Okay, sir. Thank you, sir.
Sir, that's all, sir, from.
So supposing this, so now the vegetation is there. Okay, the patient is still in heart failure, not responding to the therapy. What will you do for the patient? Like suppose you want to go for surgery. What will you plan?
Sir, either mitral valve repair or valve replace.
So suppose mitral valve replacement, which valve will you choose?
Sir,
I think you have discussed it yesterday.
yes, sir, yes, sir. Sir, if we want to prevent anticoagulation, then we will go for bioprosthetic valves. And since the age of the patient is on the higher side, we can go for the bioprosthetic valve since their life is not as long as mechanical valve. The we can use mechanical valve if the patient is younger, and we think we can continue the lifelong anticoagulation.
Okay. So here now, see, in medically now all these things become important. So you cannot just like randomly say that it is higher age or lower age. You should give some specific age. Like above this age, you will consider this. Below this age, you should consider this.
Okay, sir.
Okay. So normally, young patient is defined as if the age is below 50, it is called as young patient. Okay. So more than 65 is called older population, or maybe elderly. Usually, it's called elderly. In between 50 to 65 is the borderline phase where patient to patient wise we can decide. Depends upon the patient indication and all. Okay. So based on your clinician or physician, they can discuss with them. They can give options to them, both of the options. So in your case, what will you prefer, bioprosthetic or metallic? In your patient age, keeping everything in mind, your history, everything.
The bioprosthetic.
Bioprosthetic. Why?
So he is 58 years of age.
Okay. So you want to prevent anticoagulation for this patient.
He is in AF, right? He is in atrial fibrillation, right?
Yes, sir.
So he is anyways requiring. He will anyways need anticoagulation.
Yes, sir.
So for that case, then if anticoagulation already is required, no, always metallic valve is much better than bioprosthetic valve.
Okay, okay, sir.
Because it is anyways requiring anticoagulation. No? There will be no purpose of putting a bioprosthetic valve in. Because both of the surgeries are done by open heart surgery. You have to anyway cut the sternum and open the heart.
Yes, sir.
Okay. No, so remember that. Yesterday also same thing happened.
Yeah, yes.
So atrial fibrillation, anticoagulation is indicated. So always we will go for mechanical valve. You read that? What are the types of mechanical valve? You are aware of that?
I will.
Okay, so read about that. Mechanical valves. What are the 3 types of mechanical valves? It's called ball cage valve or tilting disc or bilifted. There are three valves. One is bilifted, tilting disc valve, and ball cage valve. Okay, metallic limits. And any dietary advice like
Sorry, sir, I wasn't able to.
any dietary advice you want to give this?
Sir, to avoid leafy products, sir, that may contain vitamin K.
Okay. So basically, we'll avoid the green leafy vegetables.
Yes, sir.
I think that's all from my side. Anything else you want to ask?
Yeah, nothing to ask. But the point is, stick to your basics. Whatever we discussed later on will only come if you clear your history and examination. And if you reach to that level where you are discussing treatment, that means you have already done well. So make sure that you reach to that level fast.
Yes, sir.
And for that, just keep your basics very clear in your mind and at the tip of your tongue.
Yes, sir.
Okay?
Yes, sir.
Yeah, these things you will be able to answer better treatment and all. So you just make sure that you reach to that level. Okay?
Okay.
You did well. Your examination, I mean, history was also good, but there are some specific points that we already discussed. Just keep practicing again and again.
Sir.
Keep presenting different cases to different people,
Sir.
and then you will get more confidence also, and you will be able to answer most of the questions because most of the questions you will have been heard from somebody previously when you are presenting to different people.
Yes.
So, and write down, I mean, whatever we have discussed, just make sure that you read these things in next 2-3 days only. It will be best way of, you will be utilizing this case presentation to maximum if you read about these things in next 2-3 days.
Yes.
Okay?
And somebody has asked about the JVP description. Somebody has asked for. So basically, see JVP if it is normal, you can just mention if it is visible, you can mention that it is normal JVP. You can mention like that. Or only if your waves are visible, or if it is abnormal only, then you have to describe the waves, each waves and any variation with the respiration or not. Yeah, otherwise, you can generally say JVP is normal with normal respiratory variation. That one statement should be enough. Only if it is abnormal or you say abnormal waves and all, or absent A waves, then you have to specifically mention about the waves also in the JVP examination. I think somebody has messaged that in the comment box. Okay. Any questions from any of the audience would you like to take? 4-5 minutes, then we may just roll it out. I think there are no more questions. Okay, overall it was a good presentation, but try to practice without seeing also, without your paper also.
Yes,
Try to practice that. Okay, your history and examination, so all part of examination should match. There should not be a mismatch between them.
Yes, sir.
So that keep that in mind.
With that also,
And
make sure that you are not lying to just match your findings. If there is no edema, you should say there is no edema. Then you should justify it that even though patient is having this, but he must have received diuretics previously. So that is why edema is not present at present right now. So don't just to match your findings, do not lie, but don't give contradictory statements also. Okay?
Yes, sir.
Okay, I think we should end our session here. Thanks everybody for joining.
Thank you, sir. Thank you so much, sir.
Thanks, Dr. Neeraj.